Hi, this is Dr. Kash. Well, I'm back in the hospital again today, so I thought I'm gonna talk to a little bit about a concept, hospice care, and which is very similar to comfort care. Um, so from time to time, we do encounter this quite often, where people ask, "What is the difference between hospice care and comfort care?" Essentially, they're one and the same in many aspects. So today, as I've been off for about a week, working from home and then going back to the hospital, there was this elderly patient who was, up until then, a few days ago, living by herself. Her son lived in the property, um, but she lives right next to him in a separate home. And lately, well, she's in her 90s, actually. She's 93. Um, but up until then, she was fairly independent and able to function quite well. But lately, she's been falling a lot. And this time, she blacked out. And so the ambulance was called. She was brought into the hospital. And upon on the drive to the hospital, her heart rate was fairly low in the 30s, which a normal heart rate, for those of you who are not familiar with it, is between 60 and 100. So 30s is kind of on the low side. Very rarely do patients not get symptomatic if it's in the 30s, but hers was low. Gave her some medications, didn't really respond that well. And there were many episode of pauses where the heart actually stopped beating for a little while, uh, lasting for about 10, 15 seconds. And during those episodes, she was very symptomatic, meaning she was kind of out of it, kind of unconscious and out of it. And so they brought into the emergency room, put a temporary pacer on her. She was kind of in and out of consciousness, and when she's into consciousness, she'll get rather combative and confused and ripping IV lines and making it quite difficult to care for her. And, they have to give her some sedative down in the ER. Eventually, at one point, the physician discussing with the family, they decided that mom has lived a good life and they just want her to be comfortable. So they want her to be put on comfort care and institute comfort care measures only. And that means that essentially everything that is done from this point forward is focused on comfort, rather than getting better, doing procedure, getting blood draw, doing all kinds of vital signs, and being very strict on certain protocols and such. But this is more of just mainly comfort care measures and just anything that is to be done uh, based on medications, based on words of encouragement, counseling, and just to really make sure that the patient is comfortable. The expectation was that this patient, probably the heart can pretty much stop any moment and she will probably pass. So that was the expectation. And the ER team called the hospitalist doctor, and which I'm one of them. So one of my colleagues who was on duty at that time went in to see the patient, and certainly followed the family's wish, and it was to bring the patient into the hospital, as the patient is no longer going to be able to go home at this point, and to institute comfort care measures, comfort care focus. And so the patient was put into a private room. And over the last 2 days, she actually woke up. Her heart rate picked up, and she actually woke up, and now she's smiling. She's able to communicate, answer questions appropriately. And the question, when I got to the patient today, the patient has been here for 3 days. When I got to the patient today, is there's been such a dramatic change in her conditions. We have not been monitoring her heart, so we're not sure what's going on with her heart, but clearly it's getting better. And so with such a turn of the event and the improvement, the question is whether the family and the patient still wants to be on comfort care, or do they want further investigation and workup? So that's quite a dilemma for both the family and myself as well. For the patient, she's 93-year-old. She has some underlying dementia, so it's difficult to trust her, whatever she was telling us. But what we know is that she's now eating, drinking, and she's clinically looking good and joking with us and talking with us. So her confusion, her combatness, and her sense of dying is clearly, at least for the short term, is gone. And so we regrouped with the family and talked to them about do we want to go forward with the comfort care measures that we instituted. And in that case, then she will be transferred to a nursing home because the son's no longer able to take care of at his home, and she cannot go home because she's weak. And so she's going to be transferred to a skilled nursing home. Back and forth after got a chance to meet with the family. Initially, they wanted to see if we can have the consultation with the cardiologist, explain things even further, and to see if interventions such as a pacemaker defibrillator would be appropriate. And sure enough, because the family have seen the improvement in her clinical status, the family has a change of heart, and they're now having second thoughts about the comfort care measures. And so we went ahead and ordered EKG. Surely now the patient is in a complete heart block, and the treatment of that is a permanent pacemaker. And so I called my cardiologist colleague, and he promptly came and saw the patient and recommended the pacemaker as well. As we were making plans for the procedure tomorrow, the family had another family members that came about, and they met again, and they talked back and forth for several hours. And finally, they decided that they no longer want the patient to have a pacemaker, which is the treatment for this condition. And so, despite the fact that the patient has shown a pretty dramatic good improvement in terms of just clinically looking good, looking well now, they said that she had a long, good life, and they just did not want to see her suffer any further. And if she was to die because of the condition, they are okay with it. Certainly, I respect their opinions. They are the medical decision makers for their mom. And so my job as a doctor's and also the cardiologist's job is to make sure that the family understands the implications of and indications for a pacemaker, and the fact that she may not die immediately, but she may, because of the complete heart block, she may fall, she may hurt herself, she may break a hip, she may fracture things, internal bleeding, which may require or prompt a recommendation for, let's say, she broke her hip, for pain control, maybe even recommendation for a hip fixation and such. And so they understand those risks. And so ultimately, they just want her to be comfortable. Eventually, we will go with the original plan. to send her to skilled nursing home tomorrow. And so because she's going to skilled nursing home for insurance purposes here in the United States, she can't be in a hospice over at skilled nursing home because the insurance normally don't cover that because they're already under the care at the nursing home. So she'll be going over there on comfort care. I mean, we call it comfort care, but essentially the care itself is very similar to hospice. And the focus is going to be on comfort, medications to help with anxiety, symptoms, pain, and if her heart should stop, her lungs should quit working, and she's to die, she will go in peace, and she will no longer be suffering over there, and she will receive the supportive care of the staff, and the family can visit over there as a nursing home. If she should live for a long time, the family will then have to figure out where she's going to go from there. Whether it's going to be going to a assisted living of some sort, or they'll find some other arrangement for the patient to go to be cared for. So that's comfort care. Now, hospice care is where if the patient said, hey, no way, I just want to go home, and if the family is going to be able to take care of the patient at home, at their home or at the patient's home with the care of the families, or if they have a care provider to do that at the private home, then we can send out a hospice program to go out to the place and provide medications, provide counseling, provide some light nursing care, but mainly the care is going to be provided by the family caregivers. Again, the focus is still comfort for the patient. And if they do get sicker, they understand that they will normally do not bring the patient back to the hospital, and the patient will die peacefully with loved ones. And so that is hospice care. So either way, this patient has shown good improvement, and whatever decision that they have made, we certainly respect that. As doctors, our job is not to dictate and to force people to make certain decisions, but to explain the risks and benefits of different treatment options, and the family or the decision maker, power of attorney of the patient, get to make those decisions. And if they do ask for our opinions, we can give our opinions, but clearly state that it is certainly just our opinion, and they don't have to go by it. So anyhow, this patient will be going to skilled nursing home tomorrow. She's surprised as all. Whether she's going to live a long time, we don't know. Her prognosis, either way, is guarded for long-term prognosis, and I wish her the best. And so I hope this kind of helped to clarify a little bit about comfort care, hospice care. A lot of time healthcare providers, we kind of throw those two terms interchangeably, and it can be confusing for patients and their families. But for this particular patient, and since the patient's going to the skilled nursing home, then she will be put on comfort care. But eventually, at some point, if she doesn't pass away and she is to go home or go to some kind of assisted living, then she will continue on hospice care, and that's will be considered outpatient care, and still focus on comfort measures as well. So I hope this helps on this topic today, and I hope you learned something. If you haven't subscribed, please do so. If you find this information helpful, I will discuss different topics from time to time, just to clarify any confusion or questions that people may have. If you have any question, you're more than welcome to drop them down in the comment section. I usually answer them as well. So good luck. Take care. God bless. Bye.